A hospital stay is seldom pleasant. Besides having pain and being sick, patients have to endure needle punctures a dozen times a day, beeps from medical equipment every 10 minutes, and moans from other patients. When a patient has a disability that does not allow them to communicate or have access to information, a hospital stay can become much worse. 1 in 5 persons in America has a disability. In medical environments, the number is higher. Since I am nonverbal because of cerebral palsy, I know the experience all too well. Nurses and other medical staff did not have time or patience to try to understand. They also may not have been trained to interact with nonverbal patients. For example, in one hospital stay, the IV came out of my arm, causing my arm to swell up and become blue. I tried to show the nurse by lifting my arm, but he did not get the hint until he actually saw the IV line. Then he blamed me for moving my arm. Other times I kept yelling because I needed to go to the bathroom or I was slipping down the bed. Nurses walked by my room without coming in. When someone would finally come, my eyes would look towards the pillow indicating I wanted it under my head, or I'd point to my pubic area indicating I wanted to urinate. Even then sometimes they could not understand me. Other patients with communication or cognitive impairments have similar or worse experiences. For instance, Shane Cecil, who has cerebral palsy and is nonverbal, became confused and scared when the hospital prohibited his mom from visiting during his 3-week hospitalization due to COVID restrictions. A woman in Massachusetts who had Down syndrome died because she kept pulling 4 tubes out of her arm because she didn't understand their purpose. Communication techniques and tools. In general, effective interpersonal communication means the exchange of information between 2 or more persons in which it is understood. Technically speaking, one individual encodes information verbally while another decodes it. Encoder, I'm pregnant. Decoder, feigns, he got the message clearly. Effective communication between a patient who has trouble communicating and a medical professional involves more. According to the U.S. Joint Commission, formerly the Joint Commission on Accreditations of Health Organizations, it entails the successful joint establishment of meaning wherein patients and healthcare providers exchange information, enabling patients to participate actively in their care from admission through discharge, and ensuring that the responsibilities of both patients and providers are understood. In July 2012, the Joint Commission enacted the Patient-Centered Communication Standards for Hospitals. Some of these standards that relate specifically to patients with communication disorders are as follows. Identify patients' communication needs. Inform the patient's assigned medical staff about these needs. Include the patient's communication needs in his medical records. Patients who cannot talk due to a disability, such as cerebral palsy or stroke, try to exchange information through augmentative and alternative communication (AAC) methods. Low-tech AAC include picture/word boards, hand gestures, facial expressions, and eye movements. High-tech AAC includes voice synthesizers and communication apps on iPads and iPhones. Learning to communicate with nonverbal patients who cannot use their hands to write is as much the medical staff's responsibility as it is that of the patient. As mentioned above, a note or booklet that includes basic information about the individual and his techniques should be placed in clear view near his hospital bed. The information also should be placed in his medical records for future reference. Additionally, a relative or friend of the nonverbal patient should consult with the medical team to reiterate his communication techniques. For example, On my information sheet I have the following, quote, "I can hear and understand perfectly. So, please talk with me as an adult in a normal tone of voice." My yes responses are indicated by nodding my head vertically, raising my eyes, or making a sound. My no responses are indicated by shaking my head horizontally or remaining silent. I also communicate with the word board, which is in my backpack on my wheelchair or in the kitchen on the bottom shelf of the radio stand. If a table is available, unfold the board on the table. Keep it folded otherwise. I use the lower knuckle of my right thumb to point to each letter or word. Please, sit on my left side and say the item aloud as I point to it. Guessing what I'm saying saves time and energy, unquote. As shown with my hospital experiences, however, informing a nonverbal patient's medical team about his AAC does not always serve its purpose. While nurses in the morning shift know that the patient raises his eyes for affirmative responses, for instance, the night shift may be oblivious of this detail. That's why the patient's caregiver should make sure all departments and shifts see the information sheet. If the patient is admitted in the hospital, the information should not only be put in their chart but also on the wall above their bed. Besides the sheet, patients should bring whatever assistive technology they use, whether it be a voice synthesizer or a mobile device with apps, with them. Patient-nurse ratio is another factor that can undermine receiving communication cues from nonverbal patients. When a nurse or aide has 10 or more patients to attend to, taking the time to decipher a patient's gesture can be difficult unless an interpreter or speech pathologist is there to assist. A solution to the nurse-patient ration is to have someone who the patient knows stays with him to help him communicate. Back in March 2020, the Office of Civil Rights issued a bulletin basically stating a friend or caregiver can be with patients who have communication needs. So if the hospital says you cannot be with someone with communication needs, tell them you have a right to be there according to the Americans with Disabilities Act. Successful interaction between nurses and nonverbal patients also is based on the nurse's desire to communicate with them. Despite being in a profession where they are likely to work with persons with disabilities, some nurses still may have misconceptions about them. When a patient who is nonverbal already is admitted, an assumption may be that he is deaf or cannot understand. Therefore, any attempt from the patient to communicate may be overlooked or ignored. According to a study done by Paddock L., Golinskia, Fong during L. Berg J. 2004, patients on mechanical ventilation have more difficulty communicating with nurses who were robotic, inattentive, and absent from the bedside. Conversely, communication becomes less frustrating for patients when nurses are kind, physically present, and informative. Training nurses and nursing aides to understand nonverbal patients has been based on the level of pain they are in. For instance, a course is offered at Suburban Hospital in Bethesda, Maryland, where nurses learn to recognize if nonverbal patients are in pain based on facial expression, restlessness, vocal sounds, muscle tone, and the ability to console. Therefore, if a nonverbal patient were in extreme pain, he would express it in one or more of the following ways: frown, moan, rigid limbs, cannot stay still, cannot accept verbal or tactical consolation. While training to recognize communication cues of nonverbal patients regarding pain is essential, the training should expand to include nonverbal cues under other circumstances. For instance, if the patient wants his position adjusted in bed, he may point to himself and look at the head of the bed. What else could it be than he wants to be pulled up? Pictures for common gestures such as asking for the time or asking for water should be posted on the wall of the patient's hospital room. Additionally, if patients have their own set of gestures, like raising their eyes to be lifted up, those gestures also should be posted. SPEACS 2 Study of Patient Effectiveness with Assisted Communication Strategies, Communications Training that covers everything from understanding communication needs to implementing communication strategies. The online course, which is free, includes 6 modules. The first discusses assessing a patient's communication needs. For example, if the assessment determines the patient cannot write, then a communication board is needed. The next module is about helping patients understand questions and instructions. The third module of SPEACS 2 shows how to communicate with patients who have cognitive impairments, hearing impairments, or language barriers. For example, a nurse can ask the patient close-ended questions like, "Are you having any pain?" Then she'd say, "Yes," with a vertical nod or "No," with a horizontal nod. Another strategy to facilitate understanding to write down words in big letters on white paper or a blackboard so patients can understand easily. The last 3 modules of the SPEACS online course covers strategies and tools that I have and will discuss in this presentation. SPEACS and similar courses should be mandatory in a medical or nursing student's curriculum. These courses should be updated to include the latest augmentative communication technologies. Speech-language pathologists at a community hospital in Boulder, Colorado developed the on-the-spot communication toolkit. Acting like a first aid kit for patient communication, it contains such tools as word and picture boards in different languages, adapted call bell for patients who cannot reach or press standard call bells, writing boards for patients who cannot talk and or hear but who can write. Other items to help patients who are hearing impaired, such as pocket talker amplifier. The toolkit was available nationwide, but unfortunately it is no longer available. However, since a communication toolkit is affordable and easy to make, any hospital speech pathologist or nursing department can assemble one. You can find all of the items on Amazon like everything else in the world. If nonverbal patients do not already have their own methods of communication, nurses could make simple word or picture boards. Pre-made boards also are available, such as Easy Board by Vedatic, Inc., which is available, you guess it, on Amazon. The Easy Board has several versions, including ICU and EMS, with specific words and phrases for each hospital setting. For instance, the ICU boards include words describing a patient's state, that is cold, scared, and desires, that is to sit up. ICU boards also include a pain chart that includes words for pain levels, discomfort types, and personal hygiene. Each board also has the alphabet so patients can spell words. Since these boards are inexpensive, hospitals can purchase them for each floor unit. Although many nonverbal individuals use voice synthesizers, they usually cannot use these devices in hospital settings for several reasons. The device may be mounted on a motorized wheelchair, which can be bulky to enter in a hospital room. Because of its custom position on the chair, the exact position possibly cannot be duplicated in the hospital bed. However, a company called IDEC Digital Systems has developed a communication device specifically for hospital settings called Eyeon Lifeline. Patients can use eye movements to activate items on a tablet. Mounted on a stand that tilts above the hospital bed, a patient can look at a square for a couple of seconds or blink at it, The device will say whatever is in that area. Thanks to the tremendous popularity of iPads and other types of tablets, patients with communication difficulties can have access to apps that function like word boards and voice synthesizers. Because these devices are compact and adjustable, patients can use them in bed. Dozens of augmentative communication apps are available for specific age groups, disability types, and linguistic ability. For instance, Phraseboard is an iPad app is like the Easy Board with scrollable options and a chart of the human body. The app also lets patients draw with their fingers if they cannot find specific words. Another app is Small Talk Intensive Care. Similar to Phraseboard, Small Talk have phases such as I have chest pain or I need suction, for example, that are accompanied by icons. If the patient can press the call button, they can enable it to speak what they need. Smalltalk also has a pain scale app that allows patients to express the level of pain they're experiencing. Again, icons accompany text to make comprehension clearer. One other app that facilitates communication between patients and medical professionals is the Patient Communicator. Besides individuals with communication difficulties, the app is ideal for anyone who cannot speak English. It translates into 18 languages. Patients can express pain levels and other discomforts. For example, they point to the stomach area on the body image and then the word nausea. Needs, for instance, pressing the square that says, I need a drink. Medical professionals and speech pathologists also can develop apps to meet a patient's specific needs. To help nonverbal patients use manual or electronic boards more effectively, nurses should repeat out aloud each letter or word that the patient points to on the board. Nurses or other medical professionals can also guess what the nonverbal patient wants to say while he spells it out. For example, if a patient points to bed on a word board, the nurse can guess if he wants his bed raised before he spells raise on the board. If patients can mouth the verb raise and then he points to bed on the board or the nurse guesses it, that would be effective communication also. A notebook also should be handy to keep track of what the patient is trying to communicate. Even if the right strategy or tool is implemented, practitioners must position the patient differently if he cannot reach the board or cannot gesture effectively. When patients with neurological disorders sit up, they usually have better motor control. Effects of nonverbal patients who use AAC studies have shown that effective communication by nonverbal patients can make them recover faster. For instance, according to Lindgren and Ames, 2005, Hinman, Jerkup, Gans, Mulayam and Cooper, 2001, Ampersand, 2002, patients spend 2 to 3 days less in ICU when they can express themselves more effectively. Patients become less frustrated, which lowers blood pressure and stabilizes respiration. Their comfort level also increases since they can communicate if they are not positioned correctly in their hospital beds, for example. Effective communications between hospital staff and nonverbal patients also diminishes the risk of medical errors. When nurses are aware of nonverbal patients' AAC cues, they can identify alert gestures such as repetitive eye gazes at and for to indicate the wrong medication is being administered, or in my case, the needle came out of my arm. Persons with communication disabilities may face similar barriers in any medical environment, not just hospital rooms. Communication techniques and strategies that have been discussed in this presentation can apply also at the doctor's office, dentist's office, radiology, physical therapy, and laboratory. You just need 3 factors to succeed. First, medical professionals should be compassionate and open-minded. Treat all patients knowing they have minds and hearts. Second, medical professionals must be trained at the college level or as a hospital requirement. In fact, the Centers for Medicare and Medicaid Services, CMS, financially rewards hospitals for such training programs. Thirdly, of course, comes the communication strategies and tools. With those 3 cornerstones, it is a win-win situation. Patients are comfortable, happy, and safe. Medical professionals know how to treat their illnesses and ailments much better with less risk of error. Thanks so much, Women in Eye Ethics, for allowing me to discuss a very important topic. If anyone has any questions, go ahead and ask.